Lovely people, the Middle East is representing today. Uh, we have our case presenter from the Middle East. We have our case discussant from the Middle East, and to make my mom proud, she never listens to these, so she claims. I will also say that I am from the Middle East, and the three of us are going to be doing the most blabbing today. But I wanted to first start by thanking three people today, even though there's only two roles to occupy. Uh, Simi was originally scheduled to scribe only for Alna to offer to give her fingers a break, but we should still hear from you, Simi. Maybe update folks on what's been going on in the last week in your life, and then we'll hear from everybody else.
Hello, everyone. Very excited for today's session, and it was very nice of Alina to cover up for me today. And as for what is new, I just ordered some online hair care stuff. So excited about that. Nothing other than that, and excited for Masa's case and Kashyar's discussion, and
Oh my
also
God.
Rob's discussion.
Oh, thank you. Thank you. I'm so tempted to ask you about that, but I know I have to leave on time today, and if we go down that rabbit hole, we'll never be able to come back. But before I hand the mic to Elena, I see a couple of people whose faces I have not yet seen. I see Brianna is here. Brianna, do you mind unmuting and telling us a little about yourself?
Hi, my name's Brianna Van Loon. I'm a LMS 4 from Lecom in Bradenton, Florida.
Awesome. Welcome. So nice to have you here. Thank you for hopping on.
Of course.
And I also see that John is here. Hi, John. I don't know if you're able to unmute. I feel like John is talking to somebody right now, not me. Hi, John. Welcome. I don't know if you're able to unmute and say hello. Trying to read the body language here. I don't think so. I think John's busy. A big fist bump to Magnus. Thank you for hopping on and turning your video on. What's new in your life the last week?
Nothing new really, but
Yeah.
very happy to be here again. Very
Thrilled to
happy.
have you. Thrilled to have you. Welcome, welcome. Elena, thank you for jumping in and scribing. Do you want to give folks I don't know how deep you want to get into your updates, but I'll hand you the mic to decide.
Hi everyone, it's good to see you. It's been a very, very long time that I did scribing, so I hope I can keep up with the case today. And I injured my foot last week, and there's one wisdom I can share as of now because I'm like chilling at home all the time. Sometimes life moves very fast, and I think it's interesting because those are the kind of things that slow you down, and you have some time out of the ordinary, and that's interesting.
I know, right? When I get, as you all know, when I get a little bit of the quote man flu, uh, I get a subtle appreciation for the value of sleep and the value of just a little bit of diastole. It's kind of silly that that's what we need sometimes to do that, but it is the life we live. Wow, we're hopping everywhere. We were just in Scandinavia, now in Germany, and now hopping over to Russia to say hi to Lyra. Lyra, what's new?
Hi everyone, my name is Lyra. I'm a medical student from Russia. And speaking of the life moving fast, I just had my last
Woo!
class in medical school.
Oh my
So
gosh.
there's just a bunch of exams left.
What was the honor of the last class? I bet it's like usually a little bit disappointing in general, but what was it?
It was psychiatry, so it was really disappointing for me because I don't really like that subject.
Yeah. Yeah, I think I've been irking the YouTube people who've been telling me to move it along and get the case started. I think you just irked all the psychiatry community, but that's okay. You are who you are. That's awesome. Congratulations on being done. I'm very, very happy for you. I think somebody else who's busy in the very, very busy in the life of a busy medical student is our case discussant today, Khashayar, who you may have not seen as much on VMR in the last couple months for very good reasons, but he really has become a pivotal member of our team, joining and being part of the VMR community for years now. Joining as a team member a little bit too late. My apologies, Khashayar. It took too long to bring you bring you on board, but I'm very, very excited to discuss with you. Why don't I hand you the mic to say hello?
Hi everyone. I just realized it has become years that I have been here. So this is doubly exciting for me today. This is the second time I'm going to be discussing. I hope Massa goes easy on me. I've been a little out of practice.
Oh, Masa is one of the kindest souls you'll meet. I think you'll be very well set up for a successful discussion. But why don't we hand the mic to you, Masa?
Hey everyone. I've missed the space. Haven't been in the seat for a while. Khashayar, don't worry. I'm gonna go easy on you. No spoilers though. But yeah, super excited to share this case, courtesy of Alec. So
Nice.
thank you to Alec again. And yeah, I'm excited to begin.
Amazing. Thank you all. It's a treat to spend this time with you all. And yeah, Masa, whenever you're ready, we can jump right in.
Okay, so we have a 70-year-old female who presents with palpitations and exertional shortness of breath for 6 days. And I'll stop here.
Yeah, very interesting. Sorry. Khashayar, what are you thinking?
Okay, so we have two key points here. First, the palpitations, and second, the exertional shortness of breath. I want to focus on the shortness of breath for the moment because I'm not really sure what to do with the palpitation, but the shortness of breath is making me focus on the heart, kidneys, and the liver with a hyperacute focus on the heart, especially given the age. I would like to know some more of the history and the background image of what we are seeing on the patient. But yeah, this is my general thoughts. I'll be looking on the physical exam for any findings regarding edemas, any things that may lead to get me away from the heart, maybe. But right now, I'm thinking, given the palpitation, there may be something acutely wrong with the heart. So yeah.
Yeah, no, I'm right there with you. I think this person's shortness of breath has two very powerful features that suggest the heart is the culprit. And the first is that it's palpitations, which is very evocative of arrhythmia. And the second is that it's exertional predominant. Now, don't get me wrong, lung disease doesn't like to walk either. But if you're asking what is stressed more when somebody exerts themselves, the heart or the lungs, the heart certainly does a lot of the work. And so you lean more towards cardiac disease. It's interesting just to take a brief moment to zoom in on palpitation. So, Khashar, if you were to make an educated guess on what palpitations usually represents in somebody who's short of breath, what do you think it often says in somebody who's dyspneic?
Palpitations
Yeah.
in someone who's dyspneic.
What is that usually like?
Um,
When you say, "Oh, this person's palpitations," what do you find as the doctor taking care of them?
I want to say atrial
Good.
fibrillations, but
Good.
I think those are just generally common. I'm not sure
Yes.
if I'm connecting with the shortness of breath.
No, I mean, I think you got so palpitations for us often mean the patient is having an arrhythmia, right? And I think the arrhythmia that we often think of is, as you said, an atrial arrhythmia and an atrial tachyarrhythmia. And I think our instinct is to often worry about tachyarrhythmias or the patients going very fast. And hopefully it's not VT, but it can be. And often it's supraventricular tachycardia. I just wanted to leave with you not something for us to dissect closely now, but for everybody to not equate palpitations with a tachyarrhythmia. I will tell you that in the ER, only 10% or less of patients with palpitations have any cardiac issues going on. The most common reason for palpitations that I see is actually the same kind of palpitations that hopefully all of you healthy people have felt, which is your heart beating out of your chest as you discuss publicly in front of a YouTube audience. That is a palpitation. And what is that's happening? That's not happening for an arrhythmia, I hope. That's happening because of a dramatic increase in cardiac contractility. And if you've ever really worked your body more than you've probably been used to, you can feel your heart beating out of your chest. And that's what most patients feel. So the most common cause of palpitations is actually adrenergic tone of the heart. Now, that can be pathologic in somebody with, say, high output cardiac failure. And so somebody's telling you, hey, I have palpitations and I'm short of breath. You may find that the palpitations are a problem here, but they're not an arrhythmia. They may be a high cardiac output. The other way that you can get palpitations outside of tachyarrhythmia, which again is very intuitive, is that there's atrioventricular asynchrony. And so when somebody has third degree AV block, for example, you might say, well, why would somebody with third degree AV block have palpitations? And the reason for that is when the atria and the ventricles are not synchronized, the atria contract on closed mitral and tricuspid valves. And that contraction on a closed chamber creates the sensation of a palpitation. So as we move practically, Khashayar, to heart here, I just want to have people to appreciate the nuance that even if it is heart, it does not equate to a tachyarrhythmia. It often is the thing we fixate on and worry about. But I will not be surprised if Masha shows us an EKG with third degree heart block. I would not be surprised if Masha shows us an EKG with PVCs, again, premature contractions in a closed chamber. I would not be surprised if she shows us sinus tachycardia, and then we would say, this person is having palpitations because of high contractility. So to summarize, palpitation is usually not cardiac. If it's cardiac, it's not just a tachyarrhythmia. It's many things, including a hyperadrenergic tone and then AV dysynchrony. So let's see what we have in store from Masa.
That was a very much needed rundown on palpitations. So she has a history of heart failure with improved ejection fraction, status post biventricular ICD. She went to the cardiologist 7 days prior to presentation for routine follow-up. She had been feeling well. Everything went well at the appointment. They told her her ICD battery was reaching the end of its life and would need to be replaced in the coming months. But reportedly, everything on the interrogation was at baseline. Once she returned home from the appointment, her symptoms started. She called about her symptoms and they told her to return the next day, where they did an EKG, which was normal. They recommended she just keep an eye on her symptoms and contributed it to a viral URI. However, her symptoms have persisted since then. She reports she can only walk around 1 block before she feels short of breath. No palpitations at rest, but with any exertion, even walking around the house, she feels like her heart beats out of her chest. At baseline, she can usually walk around the house and a few blocks without any limitations. She doesn't have any orthopnea or PND or any significant lower limb edema. She sleeps on 2 pillows because of back pain, but she's not sure if she could lay flat because she hasn't tried. She doesn't have any fever, rhinorrhea, cough, chest pain, GI or GU symptoms or any other issues, and she doesn't have any recent sick contacts. And I'll stop there.
Amazing, Masa. So well presented. Thank you. Yeah, Khashayar, what happened to your calculus now?
I'm actually going through the past medical history again. So we have a history of a battery that may need to be changed sooner than anticipated, which is just interesting to think about. But not much has changed, honestly. We have a background of a picture that we know is going to be having problems with the heart. We were expecting that. We already saw a history that is supporting that. A lack of edema and orthopnea and any other acute symptoms other than the shortness of breath is making me relax a little bit, but I'm still worried given the initial normal EKG. I may want to put the patient maybe on monitoring, but I think it's too soon for now because we may be missing some spikes here and there. And with our discussion on the palpitation, I'm more leaning towards the paroxysmal beats. I may be forgetting the name, those that come randomly and make spikes that cause palpitations. And I know those can lead to the heart being more exposed to a chance of failure. So we may be seeing those as well. But yeah, these are my general thought. I'm still in the same space, a little relaxed, want to do more tests and monitoring.
I'm so glad I'm so glad that you essentially were worried about the heart, and now, as you just said, you have more reason to worry about the heart because this patient has such a rich cardiac history. What's your take on patients? Maybe I could ask you even more directly. When you hear that somebody with heart failure has an ICD, what does that tell you about their heart failure?
Um, what does it tell me?
You could think about it another way. Do all patients with heart failure have an ICD?
I'm thinking through the pathophysiology, the change in heart may be more of a dilation that is causing delay in the circuitry that may have caused us to
Yeah.
go for an ICD, but
Right.
I
No, you're
can't
right.
remember the
You're
yeah.
exactly right. I mean, I think that essentially the heart is diseased, and so we put in an ICD. And the question for you is, has every patient with heart failure gotten an ICD that you know of?
No.
Right? Yeah, exactly. No. And so there must be something about patients who have with heart failure who get an ICD, and that feature is either they've had the disease you worry about the most, VT, and you're getting an ICD for what we call secondary prevention, or your heart failure is so bad or was so bad, despite treating it, that we put it in for primary prevention. So the indications for ICD placement are you've had VT, you need it, or that you're at such high risk for VT because your heart disease is pretty advanced and you did not respond to guideline-directed medical treatment for a certain period of time. So here it seems that this patient had BIV ICD placement for primary prevention since we don't have a history of VT yet, though that may change. And so that tells me that her heart failure must have been pretty bad. And that's concerning. So this is not just heart failure. This is heart failure, all caps. And I find that to be very, very intriguing. If we analyze her symptoms that she's coming in with, now that we're even more concerned about her and what she has, you're right. Like, she only has exertional symptoms, so at rest she's probably okay. It could be much worse. But it makes it so much harder to figure out what she actually has, right? Because she doesn't seem to have acute decompensated heart failure based on her history, though of course we need to examine her to continue to modify that hypothesis. So if we take heart and say heart plus shortness of breath, the most common cause under that equation is acute decompensated heart failure, right? So now we're having to think about the exercise Khashayar of somebody who has cardiac plus dyspnea, and we're having to think past the most common cause because it's not already apparent. So why don't we make a comprehensive checklist of how can the heart cause shortness of breath if the most common cause, acute decompensation, is temporarily put to a side? What else would cross your mind in general? And then we can try to see what applies to this patient.
And we're thinking about the heart specifically. We're not
Yes.
going outside the heart because I was like thinking about PE and stuff like that, but we're not thinking those. So I'm thinking that the heart is not responding correctly to the activity. Like the rhythm is not enough.
Excellent. Yeah.
That is my first thought.
Excellent.
Besides failure,
Yeah.
I'm thinking maybe problems with the valves.
Beautiful. Yeah.
But I can see how those would present acutely in this setting right now. And okay, we have the valves, we have the chambers. The chambers are not currently a concern, and we have the vasculature.
Good.
So yeah, problems in there. We could have acute closure of them, maybe.
Very good. Yeah, I'm right there with you. I think that whenever you have acute decompensated heart failure, whenever you have heart failure and you don't have evidence of acute decompensation, you got to think about arrhythmia. You have to think about ACS. And only after you exclude ACS and arrhythmia do you start to entertain less common causes. So my checklist is I'm worried about cardiogenic shortness of breath. Do I find evidence of venous hypertension, acute decompensated CHF? And if not, it's all about what the EKG shows. Does it show an arrhythmia or does it show ACS? And after that, it gets very interesting. But I'll leave it at that and see what Masa has to say so we can move along the case.
Okay, so for her past medical history, she has heart failure with improved ejection fraction from likely chemo-related non-ischemic cardiomyopathy. She has left bundle branch block status post biventricular ICD, paroxysmal AFib, hypothyroidism, breast and endometrial cancer, both in remission. Her drug history, she's on furosemide, aspirin, atorvastatin, levothyroxine, lisinopril, metoprolol, and rivaroxaban, and she's adherent to all her meds. Her social history, she's a former smoker. She doesn't use any alcohol. She lives with her brother and is independent at baseline. Her family history is non-contributory, and she has no known allergies. Her vitals are stable, blood pressure 147/68, pulse 60, temperature 36.5 degrees Celsius, respiratory rate 18, SpO2 98% on room air, and BMI 38.86. On general exam, she's alert and oriented ×3. She's not in acute distress. She's comfortable in her chair. Cardiac exam, she has regular rate and rhythm, no murmurs, no JVD, trace lower limb edema, ICD is in place. Her lungs are clear. Her abdomen is soft, non-tender, non-distended. She has no rashes on her skin, and that's it. I'll stop here.
Oh, and very interesting. Khashayar, she looks great on the exam, right? Normal. So, no problem, right? What do you want to do? I'm curious. You have this patient for you. You have a completely normal exam. I'm curious what you think about why that exam may be normal. What do you think?
The only thing on the exam that worries me is the blood pressure, which I don't think the history could explain. But
Yeah.
other than that, I'm just thinking sick, not sick. The patient
Yeah.
is not sick. I can relax a bit.
Right.
And next steps, I want DKG. Like
Yeah.
normal exam does not explain the things that I was thinking about.
Right.
Actually, the things that I was thinking about can present a normal finding because arrhythmias are not always there.
Yeah. Yeah, exactly. So,
So
this is why you have to build everything. Everything is built upon the history. If you show me an EKG, I can't get anything out of it really. Unlike David, Zachariah, and some other people, I can't get anything out of it until I talk to the patient. That's who I am. So let me tell you a patient I saw yesterday, Khashayar. He said, "Hey doc, every time I eat, I have really bad pain in my chest." What do you think his exam was when I examined him?
normal cardiac.
He says, "Every time I eat, I have chest pain." When I examined him, he was not eating. By the way, if
So
somebody's eating while you're examining them, I guarantee you they're okay. Just as a side point, future clinical reasoning pearl. Every time I've seen somebody walk into the ER with a sandwich and eating it, they're fine. Guaranteed. But yeah, you have to examine the patient's not saying that she has any trouble at rest. And we examined her at rest, right? She doesn't care about
we
rest.
gotta walk the patient always.
Exactly. You don't have to walk them every time if you see that they're short of breath at rest, you already know what's going to happen, right? But if she's saying to you, "Hey, I'm fine at rest. I'm only visiting you because I have trouble when I walk." And so you're like, "All righty, let's walk." So all too often, these patients get whisked away in a bed and placed flat with an IV, a telemetry, a blood pressure cuff, and they're now basically
Completely fine.
Yeah, before you do things, walk this patient. That'll tell you a lot. And if she can sprint down the halls of the emergency room, then you're like, why is this happening? Is it happening not because she has a problem, but maybe her ICD has a problem, right? Maybe that's the issue. Maybe the battery being low, some other things can happen with ICDs because you can't walk the ICD itself. So I think that I just want to emphasize that that's really, really crucial. So odds are in a very, very busy emergency room where this patient was seen busier than my emergency room, that may not have happened, but I just want to emphasize for you all, it's really, really key. So ultimately, I'm coming to the same conclusion you're coming to, which is that this is not the exam that the patient really wanted us. This is the exam we should do, but this is not the exam that we should fully invest in. Now that we know she's okay at rest, which she said she was, we now believe it because we see it. Now we proceed to see what she does, but let's just proceed in the order that naturally happens, which is most busy situations, you don't have time to do that. So I'll hand the mic to you, Masa, to tell us the next outline.
Okay, so on labs, her metabolic panel was normal, CBC normal, troponin normal. Her BNP was 268 with no recent comparison, but prior decompensation many years ago was around 1000. Her thyroid function test is normal. Flu, COVID, RSV testing negative. Her chest x-ray was clear, and I'll share her EKG.
This is the moment you've been waiting for, Khashayar, huh? Talk about palpitations. Are you getting any right now?
One
She
sec.
said she was gonna go easy on you. Look at this, an EKG. Oh my gosh.
Okay, can you see it?
Yes, looks great.
Yeah.
What do you think, my friend?
Okay. Let's kind of zoom in. All right, let's just do classic reading as all of my heart attendings say. Let's look at all the waves one by one. I want to first identify the P waves, and in the I can see some P waves, but in leads like lead 1, 2, and 3, they're more apparent, especially in lead 3, which gives us like the whole readings.
Yeah, good.
But yeah, the P waves look fine. Getting to the QRS, we see the irregular shapes that I think we can they can be explained by the ICD, especially these spikes that are kind of typical of the pattern of them. And T waves look okay in lead 3. Initial impressions, I'm not seeing anything that is concerning to me, but I need to like go into more
Oh
depth.
no, right there with you, right there with you. Sorry, one of my residents is texting me. Just give me 1 second, but I'm right there with you. I also don't see anything emergent. I'd love just to pass a question to you, and then hop back in with you. Is you said these are pacer spikes, so she has an ICD, and she here is being paced. I'm curious what that does for you when you think about ICD versus pacemaker. What do you know about that space?
I think okay, I may be thinking wrong here with the namings, but I know there was one of them which didn't pace normally. They would only pace when you went into VTAC.
Right.
And there's the other type which regularly paces you, and I think what we're seeing here corresponds to that.
Outstanding. So
We
let's
can
take a
see
moment.
the spikes.
Yeah, 100%. Let's take a moment to understand the space a little bit better. So an ICD is designed to deliver a high voltage shock to patients in malignant tachyarrhythmias. That high voltage shock requires a large coil that you can obviously see on the chest x-ray, large coil. I don't know, maybe Lyra or Alana, if you're able to look up a classic picture of an ICD on X-ray, feel free to share it since you're co-host. If not, no worries. But an ICD would have a really large coil. Pacemaker is designed with thin electrodes just to pace, and it's much smaller on the X-ray than an ICD. An ICD has the big coil to zap something with a lot of energy, and of course, naturally has the ability to zap you at low energy to pace you. So an ICD can pace. It just uses the same tools, except it doesn't use 300 joules of energy. It uses a small amount. Amazing. So on the right, you're going to try to see, yeah, perfect. Thank you so much, Lyra. So you're seeing the massive coils right there. They're very well pointed out. So if you look up a pacemaker, you don't see the thick coils that you would in a defibrillator. Thank you so much, Lyra. So an ICD has the capabilities of a pacemaker and to shock at a massive energy. A pacemaker can just pace. So we're under the impression that she has an ICD, but it's interesting because Masa told us that she had an ICD for a left bundle branch block. That could be because she has a true ICD, or it could mean that she has what's called CRRT, cardiac resynchronization therapy. Cardiac resynchronization therapy is meant to have a pacemaker lead in the RV and a pacemaker lead in the LV, and to simultaneously pace both the RV and the LV in patients who have heart failure and a left bundle branch block. The left bundle branch block impairs the RV and the LV to synchronize well together. In somebody without heart failure, that is a mild perturbance that we all can tolerate. If somebody has advanced heart failure, then their ability to tolerate that perturbance is reduced. What do most patients in her circumstances likely have? They have both. And I think Alec is just clarifying that. Because you have a low EF, you need a defibrillator. And because you have left bundle branch block and you want to be able to have the synchronization therapy, you have both. So what's happening on this EKG? She's not being shocked, but she is being paced in the LV as a result. She's being biventricularly paced as a result of her left bundle branch block. So she has a normal sinus rhythm, and instead of going down the left bundle naturally, which would create her RV and her LV to contract at different times, which might cause her symptoms, she is now getting a shock in both at the same time, so her RV and LV are contracting synchronously. Okay, does that clarify things for you?
It does actually, and I think the initial hypothesis of maybe a rate response malfunction that was mentioned in the chat can be better explained by this, as I think if this was a scenario in which we would shock the heart, we would see a refractory period between the shock and the start. So if this was a malfunction, we would see those instead of a completely normal rhythm.
Beautiful, exactly right. So the difficulty is if you just look at this EKG alone, I don't think, I'm not an expert in this stuff, but I don't think there's anything wrong with this. This is exactly what we were hoping for it to do, right? We were hoping for her bundle branch block not to work, but now the question is, since she has no evidence of ACS so far, no evidence of heart failure, she has no evidence of an arrhythmia now. The question is, does she have an exertional arrhythmia, or is something happening with her when she exerts herself? So I think what we'd really want to do is to watch her walk and see what happens to her EKG. All right, Masa, I'll hand the mic to you. What do you have next?
Okay, so as you said, her EKG, it was normal. It was V-paced and similar to prior EKGs. So then an echo was done, which shows a normal left ventricular size, moderately increased wall thickness, an ejection fraction of 50 to 54%. Septal motion is consistent with pacing. The device is present in the right ventricle. No pericardial effusion, normal valves, and compared to an echo done a month prior, it was unchanged. A trial of diuresis did not improve her symptoms. So the device rep was called for device interrogation, which showed more than 99% biventricular pace, no shocks, no atrial tachycardia or AFib, no VTach or VFib, no antitachycardia pacing. They noticed that at her recent outpatient visit, settings on the device have been adjusted in attempts to conserve battery life. They noticed that with any setting adjustments, it reproduced her symptoms. I'm gonna reveal the diagnosis after this.
All right, Khashayar, what do you think?
So we were thinking about maybe the ICD may have been the cause here, but we need to now explain how a setting adjustment may be reproducing the symptoms. So this has probably to do with how the ICD responds to activity, but I don't know about these devices honestly to comment on it.
Yeah, I think the beauty of this case is I think it's so powerful to really study what she is saying. She's saying I'm fine, but as soon as I walk, I get into trouble. And you have examined her head to toe, evaluated head to toe, and found that everything's fine, but when she exerts herself, she gets a problem. And I, like you, have not been in the landscape of ICD to understand specifically what is happening to her, but that history alone pins it to the idea that what should happen to her when she exerts herself is that her heart rate needs to increase, right? And so if she did not have an ICD and had a normal conduction system, she would increase her heart rate. And so I would only speculate the idea that her settings have been adjusted in a way, probably to conserve battery, to interfere with that natural need for her to increase her heart rate when she exerts herself. I'm not, yeah, I've come across these kinds of issues with pacemakers, but have not studied them in any detail to be able to share with you with any confidence. But I think the ability for us to localize the lesion to wanting to know what is happening to her heart while she's walking is as far as I can take it, like you. And this case will probably push me to finally open up my dirty old residency notes and fine tune it. But I can't offer you anything more than the notion that I think, like you, this has to do with the fact that when she exerts herself, she needs more from the pacer function of the ICD, and that possibly because of battery preservation settings, that demand is not being met. But that's as precise as I can take it. Is there anything else you wanted to sprinkle in before we learn from Masa?
I'm just reading the chat. Ethan mentioned that exercise may lead to a misinterpretation of heart rhythms, which may lead to a shot. But what is interesting here is that, as Alec mentioned, these inappropriate shocks would mostly show up on the device interrogation. So again, I would love to learn more from Masa, but this is getting really interesting.
Yeah, what will be fun to do is, unlike something we haven't done this before, but we probably will end a little bit early. So instead of doing breakout rooms to try to get the diagnosis, we can do a few minutes breakout rooms to reflect on what we learned from Masa. So why don't we go ahead and do that?
Okay, so cardiology was consulted, and given the recent change in her device settings with triggering of her symptoms, she was diagnosed with phrenic nerve stimulation as the underlying driver of her symptoms, and her symptoms resolved after reprogramming the vectors. So phrenic nerve stimulation is seen in about 30% of patients on cardiac implantable devices, mainly on CRT or cardiac resynchronization therapy with left ventricular pacing. That's because the diaphragm is in close proximity to the left ventricular wall, which is most commonly where the lead is usually placed. And so if there's any high output pacing or lead migration, it can stimulate the phrenic nerve. And so patients will feel this will cause like involuntary diaphragmatic contractions. So patients start feeling like fluttering in their chest, hiccup-like sensations, palpitations, and shortness of breath on exertion. And this most commonly happens like right after implanting the device, but it can happen years later. In this case, it happened almost 10 years later, and it can be difficult to diagnose because everything looks normal. And so playing around with the vectors and seeing if it induces symptoms or if adjusting the vectors relieves the symptoms can definitely be helpful. And then some other differential diagnoses include dyssynchrony, where even though biventricular pacing is more than 99%, it doesn't mean that both ventricles are synchronized mechanically. So they're paced, but they're not, like their contractions aren't effective. But in this case, there would be signs of worsening heart failure, which is not seen in phrenic nerve stimulation. And then other things can be a fusion or a pseudo-fusion beat. And it's basically when the intrinsic conduction happens at the same time as pacing. So the QRS complexes will like go on top of each other. But with fusion beat, the pacing actually contributes to depolarization. And this can, from what I learned, is that it actually can be encouraged by cardiologists because they want to encourage intrinsic like QRS depolarization. And so like the mix of both can be helpful, but it can still result in symptoms. Whereas in pseudofusion, they happen at the same time, but the device doesn't actually contribute to depolarization. So this is always pathological. But again, symptoms can include worsening signs of heart failure, which is not seen in phrenic nerve stimulation. And then another diagnosis would be suboptimal vector reprogramming or programming, which is basically when the lead stimulates scar tissue or non-target myocardial areas. And so this will result in ineffective ventricular resynchronization. So I learned a lot from this. I read a lot. So I hope you guys learned as well something new. And yeah, that's it.
Awesome. That's incredible. I know you have a big passion for cardiology, and the clarity with which you explained all that was awesome. That passion is burning through. It's so funny because for those of you who subscribe to RLR, I presented a case of this diagnosis to Reza, and it was a very eye-opening experience. I made the critical error here of assuming that this diagnosis was ruled out by the device interrogation. And I think what you were just teaching me now is that it requires more than just interrogating the device. It requires analyzing the device in more complex manners, i.e. studying the vectors. Well, actually, maybe I want to learn from you, Masa, with more precision than what's left in my mind. So I'm curious, we can also lean on Alec as well if you don't know, but I'm curious, what was the second time? So beyond re-interrogating the device in a more nuanced way, how did you go from, oh, device interrogation, no answer, to device re-interrogation, answer? Do you know how that was done? Or maybe Alec can shed light on it, if not.
So, like, you mean like how in her appointment it didn't show up anything?
Oh, no. So in the way it was diagnosed in my cases, I called for the device rep to interrogate the device. And the device rep, says, hey, yeah, there's 99% BIV pace, but it looks like the diaphragm is like, I don't know how they figured out. It looks like while they were messing around with the ICD, they were like, oh wait, the ICD is stimulating the phrenic nerve. So I'm more trying to understand what cardiology did that the device rep didn't do. And I guess we can try to.
Good question.
You know what I mean?
Yeah,
I can.
Yeah, go for it. Go for it. Please enlighten that.
No, yeah. So I think when she went to the clinic, it was just for a regular follow-up, and so the interrogation was just to be sure she wasn't having like subclinical AFib or VT or anything that wasn't being picked up. So that initial interrogation wasn't really designed to pick up any pathology because she wasn't having any symptoms at the time.
I
So
see.
I think so. What was less clear, and because I came on service and inherited this patient
Yep.
sort of on her last day of, or
Mhm.
like 2 days before we had made the diagnosis, but um, so it wasn't clear in the notes that they had changed anything on the device. So we were a little thrown off about what had
Oh,
changed. And then
yeah.
once we found that they had done something with the device to conserve the battery, when you interrogate the device, unfortunately, there isn't a direct way to say, hey, we think that this is causing diaphragmatic irritation or not. There is some literature that you can look at the actual like fibrillation on the tracings to see if it could be more suggestive that it's coming from the diaphragm and not actually electroactivity of the heart, but none of this has really been validated. So what they had recognized is that when they had changed the vectors that they were using to pace, and they had noticed that once they returned to her prior settings, that her symptoms weren't there anymore.
I see.
And so that the ability to change it around was made them think that it was more from diaphragmatic irritation. And I definitely had missed this. I wasn't even really thinking about it. I did remember your case that you had presented to Reza with the coldness and everything. But I think I asked the EP doc about it later, and she said, this is very uncommon, especially this far out, and that it's a very, very difficult diagnosis to make. And it's really just ruling out all the other things and then looking at the subtleties of changing the vectors and see if that can reproduce the patient's symptoms.
I
And
see.
then ultimately, they thought that her lead had migrated a little bit too far, close to the diaphragm, so they ended up having to extract it. But yeah, it was a really very interesting case and humbling case. And then sort of like the intermittent nature of it was also something very unique. And Masa did an awesome job presenting and teaching about that. And I loved your guys' discussion.
Yeah, no, thank you so much. This is awesome. It's very, very like I think ultimately like, what do you do differently? You restore her prior settings and you see that she's better and you're like, okay, well, what did those other settings do? And they didn't seem to affect her cardiac electrical activity as evidenced by the EKG that Masha showed us. So you're like, okay, what else could they have been zapping? And I think the phrenic nerve that's a really nice way of proving it. I hadn't thought that through. Thank you so much, Alec, for the explanation and for the case. Khashar, what are your thoughts, reflections? What do you think you learned?
So, the first and most important thing for me here is that from the initial presentation of something being wrong with the battery, that you may need to change that, you are thinking about the device, but you have to go carefully through everything and exclude everything before you go and, okay, I've tested everything. It's definitely the device. And finally, I don't know a lot about how generally these pacemakers work in their settings and how we interrogate them. And it's an opportunity to reflect on that. And yeah, I learned an interesting lot about it, that how the anatomy can be affected by these devices. Yeah.
I completely agree with you. I think that you very quickly latched on to the idea that this was cardiogenic shortness of breath. And I think the lesson that we learned, the big initial lesson to even know where to go is that cardiogenic shortness of breath without acute decompensated heart failure is arrhythmia or ACS. And I think here, this is a fascinating way that the world of arrhythmia is complicated by the presence of an anti-arrhythmic device, which can induce the arrhythmia of the diaphragm, which is absolutely fascinating. Yeah, I have a lot to reflect on. My biggest lesson is this case for me really shows how medicine is not learn and done. It's learn, forget, relearn, forget, relearn. I spent a lot of time reading about phrenic nerve stimulation. And as I just showed you all, I still had a lot of knowledge gaps. And it's because I haven't refreshed my memory for about a year and a half since I presented it to Teresa. And so when you all experience that somewhat frustrating thing where you're like, hey, I spent so much time studying for this, but how did I forget it now? I encourage you to realize that that's just the reality of how minds work. You can't remember everything that you learned. There's always a natural forgetting curve. And the only way to maximize what you remember is to continue to expose yourself to the same things over and over again rather than pretend that you've learned something for life. So I'm really, really excited to spend some time today fine-tuning and relearning about this. So thank you, Masa. Thank you, Alec. It was a real, real treat. And talking about repeating and repeating, I'll hand the mic to Lyra to take us through the learning one more time.
Yeah. Thanks everyone for this amazing case. So it started off with a history of 70-year-old female that presented with acute palpitations and exertional shortness of breath. And with shortness of breath, we talked about dyspnea pyramid. We have like lungs at the bottom, heart, and then everything else like anemia. So thinking about the patient, the age of the patient, her past medical history of heart failure, presence of palpitations that basically anchor us to the heart, and exertional nature of the shortness of breath make us prioritize the heart problems over everything else. Then we talked a little bit about palpitation and common things being common. We were mostly concerned about atrial tachyarrhythmias, especially things like atrial fibrillation. But we also talked that palpitations doesn't equal tachyarrhythmia. And the two other causes for experiencing palpitations could be dramatic increase in cardiac contractility and cardiac output, which basically represents a state of catecholaminergic excess. And also the second option would be atrioventricular asynchrony, and the most common cause for that would be third-degree heart block. And we also talked that normal EKG that this patient initially had doesn't rule out the story of anemia because arrhythmia, because it can be paroxysmal and can escape our attention sometimes. Then we talked about heart syndromes in form of heart plus one something. When we talk about heart failure plus ICD that the patient did have, we talked about the indications for ICD. And basically, there are two options. Either it's a primary prevention when patient already experienced episode of VT versus secondary prevention when the patient heart is so sick that we're really worried that she's gonna develop VT at sometime soon. We also talked about heart plus shortness of breath, and the most common cause for that to explain this constellation of symptoms would be acute decompensated heart failure. But we weren't really getting a flavor of heart failure decompensation here. So we talked about two other main options, which are arrhythmias and vasculature causes like ACS. Then we talked that normal exam doesn't mean healthy patient. And since we're already worried about arrhythmias, EKG should be a part of our physical exam. And then we talked about if the patient tells you that they're fine at rest, we need to walk the patient and see what happens, what changes with exertion. Then we talked about cardiac devices, ICD versus pacemaker versus cardiac resynchronization therapy. And we learned that ICD is designed to deliver high voltage shock if we see evidence of malignant tachyarrhythmia like VT. And pacemaker is just the backup generator of electricity for heart when it fails. And cardiac resynchronization therapy is combination of these two things. Basically, it's two in one. It can shock and it can pace the heart, which this patient did have. We also talked about then a little bit about exertional symptoms, which basically means that the heart doesn't meet the demand for increased heart rate with exertion, or in the setting of implanted CRT or intracardiac device. We talked about the possibility that exercise may lead to misinterpretation of the heart rhythm and unnecessary shock. So for that, we need to perform the device interrogation, which in this case was normal. And we need to then think what device interrogation can miss. And one of the options was phrenic nerve irritation, which basically is the final diagnosis in this case. And to learn more about the phrenic nerve irritation, you need to rewind this session and listen to amazing masses learning and teaching. Thanks, everyone.
Lyra, even though the world has a mental health crisis, I'm really glad that you're not going into psychiatry and are going to be an internal medicine doctor. I think it is showing more and more and more every single time you do teaching points. Thank you for an outstanding job. Thank you, Elena, for scribing, Khashayar for an outstanding discussion, and Masa for absolutely amazing teaching at the end and presenting a case that wasn't your own. It's not easy. And a big shout out to Alec for handing us this case. And yeah, wonderful hour. Thank you all, and excited to see some of you tomorrow. Bye.